Okay, good evening, everybody. Let's start with this particular program of live demonstration. I hope all of you are ready. And we have a couple of subjects who have agreed to have a demonstrations, and these are people who have already their reasons. And most important thing is we have the reports in the previous sessions, and we'll have a report right now. So let's see how much change it has happened over a period of time. It's very beneficial for patients like subjects who had their previous echo done so that they know whether their lesion is improved or their lesion is reduced. So both the things, sequential learning also, as well as the patient's benefit. Patient gets to know like, look, their lesion is becoming better or same or it has deteriorated. So with these few words, let me stop sharing my slides and I'll request my coordinator, Mrs. Inaduva, to share her slides so that we can get going and see the presentations. We have with us Mr. Jaili, who's about 5-year-old child who has been previously diagnosed with some illness. I'm not going to tell you what illness it was, but diagnosed with some illness, and he's over here for a sequential examination again. So we'll scan this one by one and see how does it behave. And all of you can see like my screen of patients with
yes, sir.
Okay, and you have to, anybody who cannot see, they have to do a double click on Giraffe Institute. So with this, let me get going. And here is a subject who has got his line flat on his back. You can see this. And have a little camera closer. Come, bring it closer a little bit. You can see him like this is a subcostal window. This is his left side. This is his right side. This is suprasternal window, and this is subcostal window. Now I'm going to keep my probe right into the subcostal window. I hope you can see it. I'm going to keep it almost perpendicular. Now look at the probe in the perpendicular position and look at the screen in perpendicular position. Is that clear? So we have a spine on top of over here. This is spine. Left side, this is left side, this is right side. On this left side of a spine, we have this pulsating structure. On right side is a structure which is changing with respirations. Is that clear? And now if I switch on my colors in 90 degree, look, this structure is, I'll just open up, widen up. This structure is pulsating. You can see a pulsations. You can see another pulsations over here. This is a branch or tributary of this aorta. And on this side, we have a venous circulations of blue color. Many of you can say why it's pulsating. We are not really sure about it. So I'm going to keep my sample volume with this pulse. And look, it's pulsatile structure. So this pulsatile structure is on left side of a screen. If I draw my, this is in center, this is left side, this is center, this is right side. And on right side, if I put my things on a blue color, I'm going to keep and show you, look, it shows up respiratory variations. Is that okay? Anyone can open the mic and say yes or no.
Yes, sir.
Okay. So once we've identified this, I'm going to angulate. Now look at my probe, look at the screen. I'm angulating my probe to right shoulder. I'm perpendicular again. I'm increase my depth. I'm opening to now shouldering towards right shoulder. And the structure which is draining into the right shoulder, the structure which is draining iris is draining into a structure which is morphological array. If you happen to look very carefully in this morphological array, this is the superior surface of array, this is the inferior surface of array. We are ups and down. If I have to go it ups and down, this is what normally our body structure is. If I freeze this body structure over here, this is right side of a screen. This is what where we have put a transducer. The first structure we encounter is RV. Here is RA. Here is LV. Here is LA. Now see it very carefully. And once we say this, we have this eustachian valve, which is attached to the superior surface of RA. And this directs the blood during intrauterine period from IVC to fossa ovalis. Now this get attached over here and directs majority of blood from IVC to fossa ovalis. I'll go back up and down again. So this becomes morphological array. So this is morphological array. The other structure has to be morphological LA. Fortunately, this is very clearly seen in this subject. Why I'm saying fortunately? You look at very carefully, we can see a pulmonic vein right over here. We have an appendage right over here. And how do I identify a pulmonic vein? I just switch on my colors and I'll start looking for a drainage. I can't see the drainage. So what I'm going to do, now look at my probe. I'm moving my probe towards I'm just holding my image and I'm sliding towards his chest on the left hand side. So this is the most important thing if you have to do any subject. I'm going back again. Now I'm just trying to keep those things together. Yeah. So this is so-called a morphological array. And I'm sliding towards his apex from subcostal window to apical window. Again, the same subject. Now this is morphological array and this is morphological L. This is not truly, but I'm trying to say like how do we slide from subcostal window to apical window. Correct? So if I have to make my apical window correctly, obviously I'll turn my subject to a fusion left hand side and make my apical window. Here is my apical window. And now you can see this left atrial appendage over here. You can see this pulmonic veins draining into the left atrial appendage, and we'll try to see all four pulmonic veins to the best possible. Before going to other side, let's just complete the subcostal window first. I'm back to subcostal window. In this subcostal window, this is my IVC and hepatic veins. These are my hepatic veins. These are all my hepatic veins. And if I do this is counterclockwise rotation. If I want to do my clockwise rotation, look what exactly happened. I'm able to open up whole of my interatrial septum. And in this interatrial septum, I can look for a place where the SVC is draining. This is my IVC which is draining over here. And on the other side, if I open up my whole of my, relax. So this is all intraatrial septum, and here is SVC which will drain. And if you happen to have an SVC type of ASD, this is the place where you should look for an SVC type of ASD. All right. Now let me just go back again and try to switch on colors over here. Intermittently, you'll see. Yeah. Now you can see the SVC flow seen over here. And to measure this is a very simple thing is put your sample volume into this SVC and that gives you an SVC flow. And look, it's a continuous flow. It's not restricted to systolic or diastolic. This is systolic forward flow. This is diastolic forward flow. And this will change a lot with the respiration every time. It's not that it will not be without respiration. And this is small reversal seen over here. Okay, then we go back to the subcostal window again. Look at my IVC and SVC. And where to measure my SVC, IVC? Junction. I have to measure my IVC at a place from this place to this place, where hepatic vein joins IVC. To measure what? To measure RA pressures. I'm not going to talk on this right now, but this is how I identify my morphological RA. And this morphological RA, as I said, is got a eustachian valve, which is attached to superior margin of IVC, directing blood from IVC to the fossa valves. Now I'm going to turn this subject to left hand side. Just pass a minute or and Javid is great. Now I'm going to apical 4-chamber view. In this apical 4-chamber view, what all we see? We are going to look at morphological LA. So I'm going to show the morphological LA now. This is morphological LA. It has got an atrial appendage seen over here. Then we have a hepatic veins, pulmonic veins. This is right pulmonic vein, and the left pulmonic vein will drain from somewhere over here. So I'm going to reduce my overall gains to focus on my pulmonic vein. And now, number of times you will not be able to see pulmonic veins. Why? Because the pulmonic venous flow velocity is 30 to 40 centimeters. So I'm going to reduce my nacrous limit to 30 to 40 centimeters. So I'm reducing my nacrous limit to almost 30. Now you can see a really good pulmonic veins seen in this subject. So here is a pulmonic vein. This is right, and a left pulmonic vein drains from this side. Maybe like we are able to see a very good things in the next subject, but yeah, you can see this. This is not pulmonic vein. This is what? This is something else. We'll come back to that later on. Here is the one pulmonic vein seen over here. One right upper and lower, and left pulmonic vein will drain from this side. You can see a blue color intermittently draining. So here is a blue color which is draining from this structure. So we identified all the 4 pulmonic veins. One is over here, and possibly this could be a pulmonic vein upper and lower. Once we have identified this, next our point of identification would be what? So what we classify them? Now we can say safely that this structure is morphological RA. And this structure is morphological left atrium. And now see this structure very, very carefully. So you have got both the things. One is right atrium, left atrium. This has got a eustachian valve. This has got a pulmonic vein over here. Left pulmonic vein is on this side and this side. And this is atrial appendage. And now look at the mitral and tricuspid valve. How to identify a mitral tricuspid valve is, let me freezing it up. Look at the insertion point of tricuspid valve is over here and mitral valve is over here. And there's a potential space between these two valves, and this is known as atrioventricular groove. And if you happen to have a shunt between left ventricle to right atrium, this is where the place happens for a Gargodes syndrome. Now look at carefully in live images. This is left atrial appendage, and this is left mitral valve attachment hinge point. This is a tricuspid valve hinge point. The valve which is apically placed is tricuspid. Valve which is basally placed is mitral. So I'll have to go back again and let's see how his valves are. Now see the attachment very carefully. This is apically placed tricuspid valve. This is basally placed mitral valve. And the potential space between these two is approximately 4 centimeter, 0.4 centimeter. Anything more than 7 is considered as abnormal. So this valve becomes mitral, this valve becomes tricuspid. Once we have mitral and tricuspid valve which are abnormal, next structure is to identify our what? LV and RV. LV is clean shaven structure. Let me just bring it, zoom it for you. Now I'll be concentrating on apex and RV and LV. So if you happen to see now over here, this is almost a clean shaven structure with the evidence of papillary muscle in the lateral wall. All of us read this is septum, this is lateral wall. On contrast, this is bullet shape in format. Then you can have an accessory band over here. On the other hand, we have this moderator band, and this is triangular, and there is no papillary muscle. Like big fat lady or big fat husband with a triangular structure attached to it. So ratio is almost 2:1. Normal structures are. And that's how we identify the left ventricle and the right ventricle morphology. Right? Once we have identified all this structure morphologically, then next point comes, what is the relationship of big chambers with their great vessels. So how do we look for a great vessel? So now look at this great vessels. All of you understand what is great vessels are. If you happen to see a circular vessel in the center and the pulmonic artery wraps around and bifurcates, that is a great vessel is atrioventricular concordance. So what exactly we learned? We learned with the situs solitus and D loop. This is, I'll come back to D loop once again because that's I missed a few minutes back. So this is what is morphological RA, morphological LA, mitral valve, tricuspid valve, LV, RV, atrioventricular concordance through mitral valve, atrioventricular concordance through tricuspid valve, and a big vessels attachment is great artery like aorta in the center and a pulmonic artery wraps around in the center. That is atrio great vessels connections which is concordant. When we talk of a situs solitus with G loops, the nature of it. When we talk of situs solitus, we do look, what we do is, as we move from this side, like perpendicular, if I go and up, look, this is what is at your level. I'm not going to explain the physiology at this moment. This is known as D loop. What do you mean by D loop is, this is anterior, this is posterior, this is left, this is right. If RV, RA, they are anterior and right to the LV and L. So LV is over here facing left hand side. Then RV, RA, they are anterior to LV and LA and slightly towards right hand side. That's what exactly means by D. So we talked about situs solitus. We talked about situs D loop. Then we talk of identifying morphological RA, morphological LA, then mitral valve, tricuspid valve, and then we looked at chambers, and then we looked at great artery connection, whether left ventricle is connected to particular aorta or left ventricle is connected to aorta and the right ventricle is connected to pulmonary. This is how we look at a sequential examination for any subject. Whenever we do that, we always look at these kind of a thing. Now, let us switching over gears. This patient has got, this subject has got some abnormalities. And I'll show you the abnormality. Any one of you can say what is the abnormality is. And for Doppler, I need a little bigger or lower frequency transducer is. I'm changing my transducer frequency to lower frequency. And again doing the same thing which I was doing earlier. Now look at change of frequency. You can see imaging has become much brighter. This is a 2.5 megahertz transducer. I'm going to take it to 3 megahertz now. So this is appropriate for this child. Again, counterclockwise rotation. And once I do this, I'm going to put my cursor into the interatrial septum first. And I'll wait if I can get any shunt which is seen over there. One window is, this is 4-chamber view. This is known as subcostal window, 4-chamber view. With a fair mode look. 5 more minutes, we are done. No shunt. So we say there is no shunt across. Now I'm going to open up, not by counterclockwise rotation, I'm doing a clockwise rotation. Now with this clockwise rotation, this is my interatrial septum. And I'm switching on my colors on this interatrial septum. Even I can't see any shunt in this particular region. So no primum, no secundum, no sinus venosus SVG type. Correct? Similarly, I'll go to short axis view at pulmonic artery. Now look at the windows very carefully. I'm going to short axis view at pulmonic artery. Now opening up a colors in this format, where this is descending aorta, this is right pulmonic artery, and there is a left pulmonic artery. If there is a PDA, this PDA would be seen over here. What will be? There will be a flow of blood from this descending aorta to pulmonic artery. So we cannot see any PDA over here by switching on the colors. And now we see a small amount of pulmonic leakage. And if it's 1/3 of less than 1/3 of pulmonic artery diameter is mild, 2/3 is moderate, and 3/3 is severe. So we do not have any PDA. So we ruled out ASD, we ruled out PDA, and we go to suprasondal window. Beautiful suprasondal window for demonstration. we can identify all the cranial vessels. Here is left subclavian, left common carotid, and here is innominate. So this is the area where we start looking for a descending aorta, coarctation of aorta. I'm going to jack up because reduce my Nyquist limit to 50. It's all laminar flow. And in case you have a doubt, what do? Just put a sample volume, take a pulse wave velocity, and then pulse wave velocity shows how much? 1.5. Then you go to continuous wave Doppler. Not much change in a velocity. If there is a coarctation of aorta, you will find a significant difference in pulse wave and a continuous wave. Similarly, at this point, what you can see is from here to here, you will find PDA also sometimes. The PDA which is not seen in parallel short axis view. Look, this is a place where the normal PDA is attached. Look, this is hole which is seen over here. This is the normal place where PDA is attached to internal pregnancy. It's not PDA, ductus arteriosus is attached to and descending, push up blood to descending air. So no ASD, no PDA, no coarctation of aorta. Now what's left? We go back to flash window again for this child. And I'm going to go to now parasonal long axis view. First view where we look for any shunts for VSD. And if you look carefully, intermittently, you can see that septal leaflet of tricuspid valve. Here is a septal leaflet of this tricuspid valve. And there is a potential gap in between. And this is before aorta. If it's after aorta, that will be a different thing. So we are looking at septal leaflet of the tricuspid valve. And normally we do not measure any defect holes, especially with VSDs. And now you can see a turbulent flow across this curvilinear structure. So this is a turbulent flow across this curvilinear structures. And I'm going to show, and now you can see a duct kind of a thing. I'm going to make it smaller. You can see a like tunnel kind of a thing which is seen in the subject now over here. And this is the more tunnel it is, the better is for the patient. Why it's better for the patient is because that will close definitely over a period of time. Tunneling is the septal leaflet has just to close over a period of time. So it's virtually a tunnel-like structure which you can see over here, the originating from left ventricular septal tricuspid leaflet and then going in this direction for a VSD. I don't think we can demonstrate you better than this for a tunnel-like flow across the interventricular septum. And this is where we put our what? We put our continuous wave Doppler. Very high flow velocity jets. This is almost, if I really take a peek of it, this is, I'll try to underestimate 90 millimeters of mercury of a gradient. 5-year-old child, so we need to have a blood pressure. If his blood pressure is 90, obviously his PA pressures are almost 0, and that's what we expect from this child. And I'm going to do it number of times, not one. Just wait. I'm going to organize my just parallel. You know, it's like the child has to be comfortable, child's parents have to be comfortable, and you should be comfortable. In fact, the gradient is going more. It's going almost to 120 millimeters of mercury. That is first window. Next window is we go to short axis view at pulmonic, short axis view at aorta. Now look what I did to talk to you. You divide this aorta into 3 parts: proximal, middle, and distal. Here is one paramembranous VSD. This is what muscular VSD. This is what? Doubly committed VSD. And if this is doubly committed VSD or subpulmonic VSD, it is almost always associated with AR. So now I'm going to show you. Now look at this, some kind of a membrane you can see over here. And if you can see this membrane, I'm going to switch on the colors. And now look, the same jet which you are interrogating in this in short axis view. And we look at this jet, and what we do is now we take a cursor, put a continuous wave Doppler, and I get a gradient of almost 120 millimeters of mercury. Very good for this child. Higher the gradient is, restrictive the VSD is. And if you happen to see a tunnel, it means this VSD will close down over a period of time without any interventions. So restrictive VSD. And one more thing, two more things. This is what is paramembranous VSD is. Then we look at inlet and outlet VSDs. What do you mean by inlet and outlet VSDs? I'm in 4-chamber view now. I put my scanning into the colors of the interventricular septum. Look, I can't see any. I can't see any flow of a color in this interventricular septum over here. So this is, if there's a VSD which is present, it is known as inlet VSD. If I expand this, open up my aorta, and then put my sample color Doppler into this ventricular septum, then this is known as outlet VSD. Now look carefully what exactly happened. So here you can see a shunt which is happening from left ventricular to the right ventricle. And that's why a number of people, they say paramembranous outlet VSD. Okay. Now, number of times we hear a murmur, but we can't see a VSD. So what we do, we go to apical segments. Like I'm foreshortening my apical views. Then closing down my two apex. And I'm focusing on my apex. In this focusing, if there is a VSD in apical segments, we'll be able to see apical VSD. So paramembranous, short, Plaques window, short axis window, 4-chamber window, 5-chamber window, and 6 is apical window. And if you can't see a VSD, possibly there is no VSD. Second thing is, once you look at a VSD, one more important thing before I stop over here, and we'll take a break and just the next patient or a subject and explain to their parents before they leave over here. We have to take what? We have to take the gradients. Gradients of what? We had a gradient of 120 millimeters of mercury. So we'll take his blood pressure and then we'll take our TR jet gradient. Now I'm focusing on TR jet. I don't expect to be a very high TR jet velocity. Look, his TR jet velocity is hardly 2 meters per second. 16. So we don't expect anything much in the subject of VSD. So we classify them as restrictive VSD, I'm doing it again. So my approximate gradient is 20 millimeters per minute. So any question which is relevant and non-repeatable, anybody can open it up, I'll answer immediately. Anybody, any relevant question? All right.
Sir, can you tell me about inlet VSD?
Inlet VSD is very simple. When you happen to see 4-chamber view and look at the cursor, look, this is 4-chamber view. Inlet means LA to LV, RA to RV. and you scan the septum. If you happen to see a VSD, that is inlet VSD. You make it 5-chamber view, like open the aorta. This is outlet as you have opened up. So if you happen to see VSD in this part, then this is known as outlet VSD.
Yes, sir.
Okay?
Yes, sir.
Very simple terminology. And this is not there for today. This is there for 1980. Soto's classification is still adopted even today also. Because septum is what exactly, if you happen to see what is inlet and what is outlet. Inlet is when we are looking for septum. Outlet is when we are looking for anterior septum. I have a little doubt over here for his muscular VSD. Let me just look it again once. Before that, I relieve him off. Many people, they ask for a size of a VSD. I'm sorry to say that measuring the size of a VSD is the most, I don't say inappropriate, but it's a very difficult thing because millimeter, 1 millimeter this side, 1 millimeter to that side will really make a lot of problems for the patients as well as for the attendants also. If today is 4 millimeter, tomorrow you say 5, they'll get apprehensive, look, it's 5. And if it says today is 3 and tomorrow is 2, they'll be very happy. This is nothing but a jet of this VSD going in this direction. Look, this is the jet going in this direction. So same turbulence which you could encounter in during your flax window. Same turbulence which you are encountering during this flax window. You see tunnel-like structures which was seen over there. So this is tunnel. And many people, they measure this VSD and they, I'm sure like we do also number of time. I'm not saying that. We do also, but that is, I feel like it's not appropriate because it's just dependent on gains when we can over modify them or under modify them. Now look, I'm going to measure it number of times. 1, 0.3. So I'm going to get rid of 0.3 first, then adjust my gains again. I'm sorry, it's coming back, say 0.3 by 3. So I'll go and take my another views, zoom up my window. Now you can see this very beautiful presentation of this. This is septal leaflet tricuspid one, and I'm very sure this VSD over a period of time will close down automatically. We have just to wait, watch, and see. This guy, this child will not need any closure any time in his life, most people. And now you can see the great tunnel. This is all the tunnel you can see over here. And this is how the VSD flow is going on. Anytime this leaflet stuck to this interventricular septum, our tricuspid valve just closes down this particular VSD. And again, I'm going to measure this interventricular septal defect. And I'm going to zoom it up this time so that I'm more appropriate. And I'm going to measure that again. I'm not seeing like 1, 2, or 3, whatever it is. So it will have many variations whenever we measure it. And with this zooming up, let me just show you the flow across the tunnel. It is Jerry, just 2 more minutes. Really 2 more minutes, Jerry. Now you can see both the VSD together. Is that clear?
Yes, sir. Thank you, sir.
So we'll stop over here for a few minutes and in a we have no, don't. Back again. I'm going to demonstrate this young child named Bhavika, and I'm going to show you the first subclaustral window again. Look at the first subcostal window. And here it is your answer. I'm going to do a counterclockwise rotation. With counterclockwise rotation, view which is seen as
Yes, sir.
bicable view. Look, here is an IVC, here is an IVC, and here would be the SVC. I cannot press this child too much. Here is an IVC, here is an SVC. This is what is known as bicable view, and which is equivalent to transverse figure. All right, we go back again. We are going 90-degree perpendicular. Revision quick. Here is spine, pulsating structure, non-pulsating structure, opening into morphological array. This is morphological LA, which you have to identify. It is there. Nothing to bother about this morphological LA. We have to identify the veins, pulmonic, and let me try to show pulmonic veins in case I am able to see this patient. Yeah, this is better demonstration of the pulmonic veins. And you don't have to confuse between atrial appendage and the left pulmonic vein. Look, this is right pulmonic vein, one over here, one over here. This is left pulmonic vein. This is descending aorta or coronary sinus. It could be coronary sinus because descending aorta is over here. And this is what the atrial appendage is over here. And how do we identify these things? We are just switching the colors. Now see, both pulmonic veins you can see over here. One is over here and second is over here. Both pulmonic veins, and right pulmonic vein is the most common thing which we utilize in a clinical practice. And we take a cursor right into the pulmonic veins. Now you can see the pulmonic venous flow in this patient. Very clear. And now we try to see a left pulmonic veins because left pulmonic, now you can see the flow which is happening through left pulmonic vein. Here is flow which is happening through left pulmonic vein. I try to open that for you. So this is left pulmonic veins and this is upper and this is lower. Now you can see both of them joining together. This is coronary sinus, here is descending aorta. His coronary sinus is a little dilated and you see some amount of turbulence in this pulmonic vein over here. Let me see, put a cursor into this pulmonic vein. Velocity is little on the high side, almost 1 meter per second. So this could be one another reason why this patient could be in congestive cardiac failure. If the pulmonic velocity, venous velocity is little high, because unusual, we just keep in mind, I'm not saying that we are going to take any action on this, but we have seen number of people where this pulmonic vein dilatation leads to improvement in congestive cardiac failure. Normal velocity is 30 to 40 centimeters. So if I look at this image again, very good depiction of mitral valve, basally placed, tricuspid valve, apically placed. Then we go to apex. Again, clean shaven structure, LV. Non-clean shaven structure is RV. And once we see all this, we go to short axis view at pulmonic artery. Rotate 90 degree and you can see a curved linear like cup and saucer shape of a structure. In this, what we see a descending aorta, no PDA, and here is the aorta in the center, and then we see some amount of color flow across this interstitial septum through this particular part. So what is possibly looks to be a paramembranous again VSD in this patient. In this patient, I have to really measure this LV, because why I have to measure my LV is this is from this point to this point, 26 millimeter, and based on Z value, anything less than 0.2 or anything less than 2 or more than 2, we decide whether this is hypoplastic, normoplastic, or dilated. So I'm going to go to Plaques window again. Parallel. And in this, if I tilt my transducer little towards up, I can see my shunt again. No, I can't see any shunting over here. I'm trying. Child is getting irritated. Some amount of mitral regurgitation is already happening. Can you see this mitral regurgitation which is happening over here? So I'm not able to see any shunt till now. Jack up a little gains. Could see some amount of mitral regurgitation. This is not rheumatic. Only 7-month-old child. Don't talk. This is rheumatic. There is no AR. So fair chances of subpulmonic VSD is out. This is a VSD, which is most probably, now you can see a definite VSD. There's no doubt about this, the VSD is not there. Let's see a gradient, and then we'll try to look at the location of this VSD again. The shunt is happening in the proximal part of this aorta over here. We are imaging, oblique imaging is there. This is almost 54 or 55. Let me just try to get to the maximum gradients. Yeah, it's a direction. If you look very carefully, the jet direction is towards tricuspid valve defects over here. And then it straightens up. This is definitely a paramembranous VSD. And let's go back to my optical window again. Why I'm not able to see a paramembranous VSD? Now look, it's seen over there. We were missing now. Can you see this paramembranous VSD? And again the gradients. Now you can see a very good gradients. The gradients are touching almost to 84 millimeters of mercury. Then we look at the TR jet gradients. Same window, outlet VSD. We should be able to see a VSD out here. Now you can see a VSD. Now look very carefully. The jet of this VSD is in a different direction as compared to the previous subject. This is hitting toward tricuspid valve now. The direction of jet is in this direction. That's why we were measuring underestimated gradient in parallel short axis V. And now it will be very difficult for us to measure our TR gradient, because whenever we try to measure TR gradient, this jet will become handy for measuring that particular gradients. So it will not be easy, and then we'll rely more on this gradients rather than a TR gradients. One more thing which I wanted to show to everybody was, go to Plaque's window, right? Go a space up. Once you go a space up, look what exactly you are seeing. You are seeing two structures. This is pulmonic artery, this is descending aorta. And this is the one place where you can see your ductus arteriosus. So what I did, I'm in Plaque's window. I've gone to fourth intercostal, second intercostal, left third intercostal space to second intercostal space. Shrikant, can you show the camera? Shrikant. Shrikant. Just go a space up. इधर जाओ, उधर नहीं बैठ। उठा लो उसको। Bring it over here. Now look at this window. I am in Plaque's window, correct? If I'm moving my intercostal space to little up, just going up one space, same place. Look, I can see two structures. This is descending aorta and this is pulmonic artery. Switch on the colors. If you can see some flow from this point to this point, this is known as ductus arteriosus. This is pulmonic artery, this is left descending aorta. Pulmonic artery right over here, left pulmonic artery. So what we did, we were in Plaque's window, in left third intercostal space. We went up by a space, and that's how we see the two structures. One is descending aorta, the other is pulmonic artery. And this is a shunt which is seen over here is descending aorta. So we'll stop it over here. And guys, again back. Let me show you a couple of examples from our machine. Go ahead.
Another thing, sir. In this patient, there is VHD also ASD. Two things. So when we call AV canal defect, sir.
When we call AV canal defect.
Yes, sir.
AV canal defect is when both atrial and ventricle, they are together. They are like working like single valve. Like ASD, primum ASD and VSD together, making like a single valve. We'll show you a common AV canal defect. Let me just show you a couple of examples from our machine. Right, I showed you this ASD. So I'll go back again. This is PFO. When you classify these people as PFO is when you have less than 4 millimeter size of a shunt across interventricular septum. Can you see this very good SVC flow? Now there's some amount of flow which is seen over here. I don't think I can demonstrate you because I couldn't see anything in this. Yeah, it's here. Some possibly flow across this interventricular septum, tiny small flow, which has been classified as PFO. I'm not this is a clear answer, but the answer is best given by agitated contrast saline. Another example, VSD with PS. Now look at this VSD. If you measure the size, although we should not, this is approximately this millimeter of size, almost 7.7 centimeters. And if you look at the color flow across this VSD, predominantly left to right, gradient 126 millimeter of gradients. On top of that, this patient has got something unique along with it. What's unique, which is trying to prevent this patient from any, and this is what is the flow across this VSD. This is somewhere like crossing over to this territory of like mid kind of a territory. But on top of that, this patient has got associated pulmonic stenosis also. There is a gradient for the pulmonic stenosis, which is almost like 50 millimeters of mercury. That was a pulse wave, and this is by continuous wave, and one more gradients, LPA, RPA. But at your level, this is what I'll say is almost 46-50 millimeters of a pulmonic stenosis gradient. Now look at the PDA. Now you can see a jet of color which is there from this descending aorta to pulmonic artery. I'll freeze for you. Look, this is what? Systole. Normally it's a continuous flow. Pulmonic artery is on top. Here is pulmonic artery. Here is descending aorta. So the flow is reversal which is happening here. This is descending aorta. You see a shunt over here. That is PD again.
Sir, is there any ductal view to see PDA in this patient?
We did not have a ductal view. My colleague was doing it. Unfortunately, we could not see a ductal view. Now this is overriding of aorta. This is VSD. Here is one part of aorta. Here is the second. This is aorta is over here. Aorta is over here. So this is overriding of aorta. Much better now.
Sir, when we call this overriding, sir?
Look at this interventricular septum is in the middle. It is draining blood from RV and LV both. Let me freeze to you. This is a VSD. Here is a aorta. This is the interventricular septum is short of this. Is large interventricular septum. This is RV, which is draining into the aorta. This is LV, which is draining into the aorta. Now see carefully. Almost 50% override of aorta. And if you switch on colors in this, you will find the colors are going in. Still, LV pressures are more than RV pressures. So you find more of a blood which is happening from LV to RV. Last, before we close. Tell me, where is the VSD? Here, mid-muscular VSD,
Muscular.
apical muscular VSD. And this should be seen equally in 4-chamber view. I hope my colleague has recorded, because she's always lucky to get so many patients. I'm not one of those lucky persons. Look, I can see a jet, but I can't see its proximal margin. So I can't tell you it's inlet or outlet VSD, but there's a muscular VSD is present. And majority of these VSD, whether they are VSDs, they're closed by themselves. Now, look, this is somewhere in between picture. Whether aorta is partially open, aorta is partially closed. So this is happening over here. So most probably this is inlet mid-muscular VSD. Again, aorta is opened up. My colleague is more lucky, but this here appears to be outlet VSD. So we have to check it up whether this is inlet or outlet. And you can be assured for these kids, because these muscular VSDs, majority, I'll say 99% of them, they close automatically over a period of time. All right, shall I stop it over here?
So can you show us the sinus venosus ASD, sir?
Sinus venosus ASD. This is what, Jigna?
Yes, sir, Jina.
Jigna, I'll show you sinus venosus ASD.
Yes, sir.
In my, not over here, but I'll show you sinus venosus ASD.
Mhm.
This is I'm showing from machines.
Yes, sir.
Okay, so I'll stop it over here. Any questions before we break, and see you next week with lesions, and just post this sinus venosus VSD, sinus venosus ASD on the WhatsApp group. Any question which you want to see, we have a live recording of everything on computer, so that we'll try to show you next week all those things. Okay,
Okay, sir.
anybody else? In a pause.